Good afternoon, and welcome to today's webinar, Fueling Recovery, Speech Language Pathology and Registered Dietitian Collaboration in Brain Injury. This is the first part of a two-part series focused on nutrition. My name is Katie Law, and I'm a Public Education Coordinator at the Brain Injury Alliance of New Jersey. The Alliance is a nonprofit organization with a mission to provide education, awareness, prevention strategies, advocacy, and support for individuals who have been impacted by brain injury. I would like to announce that we will be hosting the second part of this series on April 28th, called How Medical Nutrition Therapy Supports Brain Injury Care. We also have a webinar on May 19th from 12 to 1 focused on vestibular challenges after a traumatic brain injury. To register for the upcoming webinars, please scan the QR codes, or you can use the link, which I will put in the chat in a moment. Okay, and before we continue, I'm excited to share that BIANJ is hosting our second annual family camp this summer. It's taking place June 25th through June 28th at Happiness is Camping in Hardwick Township, New Jersey. Our family camp is an overnight experience designed for families affected by brain injury. If you are interested in joining us, you can scan the QR code on the screen, and I'll also put the registration link in the chat as well. Now, just a few housekeeping notes before we begin the presentation. Attendees' microphones have been muted. If you have any questions during today's webinar, please type them in the Q&A box. We will get to as many questions as possible at the end of the presentation. The webinar is being recorded and will be available for viewing on the BIANJ website. At the end of the webinar, a link for a post-webinar survey will be placed in the chat. We value your feedback, and you must complete the survey in order to receive a certificate of attendance. Once you complete the survey, you will automatically receive your certificate of attendance via email. Our presenters for today's webinar are Jennifer Breidenbaugh and Kellyanne Pena. Jennifer is an assistant professor at the Department of Clinical and Preventative Nutrition Sciences at Rutgers School of Health Professions. She has been a registered dietitian nutritionist for over 30 years. Jennifer began her career in the neuro and surgical trauma intensive care units and continued working in acute care settings, maintaining her expertise as a certified nutrition support clinician. Throughout her career, she has provided medical nutrition therapy to individuals with a wide range of needs, including chronic disease management, malnutrition, and acute or long-term nutrition support. With more than 20 years of experience teaching and mentoring students in clinical nutrition and other health professions, Jennifer currently teaches advanced clinical and medical nutrition therapy to graduate nutrition students. She is passionate about her interprofessional education and presenting the nutrition profession in collaborative healthcare practice. Kellyanne Pena is an assistant professor of speech and language pathology at the University of Pittsburgh and a bilingual speech-language pathologist, specializing in brain injury, disability navigation, and migrant health. Her work bridges clinical practice, education, and mixed methods research to examine how trauma, TBI, and executive functioning are misrecognized across educational, medical, and legal systems. A former assistant clinic director at Rutgers University, Kelly is committed to culturally responsive, trauma-informed care and to expanding access for bilingual and immigrant families. She brings a systems-level lens to clinical education and advocates for equity-centered approaches to assessment, rehabilitation, and care coordination. Now, I am pleased to welcome our presenters, Jennifer and Kelly.
Thank you, Katie. I'm going to go ahead and share. If you want to unshare, then I'll share my screen.
Okay, you should be good now.
Okay, terrific. Can you all see that okay? Awesome. All right. Okay, well, thank you all so much for coming today. My name is Jennifer Breidenbaum, here with my colleague Kelly Pena, and as Katie mentioned, there'll be sort of a part two to this, but regarding nutrition and brain injury. But we really can't talk about nutrition and brain injury without talking about the collaboration that's necessary to treat individuals with brain injury. And we feel, we may be biased, but that the speech language pathologist and the registered dietitian is really the most important collaboration in this population. So we felt it was appropriate to start this series with talking about the collaboration between our two professions, and we'll provide a case example as well. So we have no disclosures. I am an employee of Rutgers University. Kelly is an employee of University of Pittsburgh. So as I mentioned, the agenda today is you will learn about the two of our professions, a little bit about what is an RD and what is an SLP. We are going to be introducing and utilizing a case study towards the end to demonstrate collaboration between our two professions. We're going to focus a little bit more on dysphagia. This is the condition that our patient is dealing with, but this is also probably one of the most common complications of brain injury that would warrant the need for our collaboration, and also what might lead to more acute issues such as malnutrition. And so we're going to talk about our collaboration as well as some nutrition-focused challenges, barriers, and what some solutions were utilized to address our patient that we are going to share with you today. So let's first take just a quick look at, it's not just us. I mean, we would like to have a panel of 7 or 8 or 9 professions here, but today we're just going to talk about the collaboration between the speech language pathologist and the registered dietitian. But there are many other health professionals that will be part of the team of brain injury care. Many of you all know this well. The physician, of course, who's going to coordinate medical management of your patient. We obviously will learn a little more about speech language pathology and registered dietitian in terms of managing things like dysphagia and complications that would impact the ability for a person to consume oral diet safely, and then what type of manipulation of that diet would be needed in order to assure that the patient is, nutritionally adequate, or consuming a diet that's nutritionally adequate. But we also have a lot of other therapists that can partner with us, the physical therapist, occupational therapist, to help with things like adaptive equipment or just improving functional mobility and assessing functional ability so that they can support their nutritional. And I'm actually kind of looking at it as a nutrition lens, but we need to make sure individuals can literally consume food, prepare food, and be able to support themselves at home. We certainly have pharmacists, radiologists that can help us when we're diagnosing an issue such as dysphagia. And we also have a lot of social and socioeconomic issues that can come up where we might need individuals like social worker or mental health practitioner. We also want to not forget our colleagues in dentistry, because there is a lot of oral health that can impact the safety as well as the safety of preventing infection, but also just the ease of consuming an oral diet. So again, just a quick snapshot of other professionals that we may partner with and collaborate with brain injury. So what is a registered dietitian? So my profession is we are nutrition experts. We are the only credentialed board certified nutrition expert that has been trained in evidence-based practice, as well as requires continuing education to hold our accountability for our knowledge and practice. But our competency, we build our competencies through training through a graduate degree program. We train our students our background is mostly sciences. We do a lot of biology, chemistry, biochemistry is really the heart of nutrition. So we have also anatomy, physiology, the coursework that really intersects science and the body. That's where nutrition lies. And we apply that nutrition knowledge to a lot of different areas. So when we're training our students, we put them where they see individuals that are managing acute care injuries, chronic injuries. So it can be acute care, subacute, long-term care. We will get students working with different disease states such as diabetes, kidney disease, obesity, oncology. We also might see an RD, or we might get the students to work in industry, in sports and performance. We have registered dietitians that are in professional athletes, work with professional athletes in sports. We also get our students to train into community partnered programs and get our and just general training along the lifespan. So our students and our RDs are able to really work with patients literally from preemies to older adults. Our nutrition is found along the whole lifespan. And then this is just a little snapshot of where you might find an RD working. But I also want to emphasize that, registered dietitians focus is also in prevention. So although we are talking about a chronic condition or, impacts of disease on a body and a patient, we also can be found more upstream where we can help with prevention of chronic disease. Certainly, we all know that nutrition can really impact someone's health outcomes. But when we have when the RD with brain injury care, we'll really begin with how we would approach any individual who requires a comprehensive nutrition assessment. And that's what we call the nutrition care process. So these bullets sort of summarize how I would approach somebody with brain injury. And we first start with assessment of their whole picture. So medical, social, environmental, food and nutrition, biochemical factors that influence their nutrition health. So we're looking inside the body as well as what's going on outside the patient's, where are they living? Do they have access to food? Are they have food security? But we also look inside. So how is the body responding to their food? Are they having any issues with like diabetes, chronic issues such as hyperlipidemia, all those things that can really be impacted by diet and gear where we could intervene. We also are evaluating those comorbidities that individual might have, that TBI or that the chronic or even a stroke or whatever it might be might have been prompted by a chronic condition such as hypertension, diabetes, cardiovascular disease. So all of that can be intervened with a nutrition therapy. We also are going to approach that patient and evaluate them for malnutrition. There are risk factors that go with patients who have brain injury that is going to put them at greater risk for developing malnutrition, undernutrition, or overnutrition. So dysphagia, a need for enteral or parenteral nutrition or nutrition support. We're also taking into effect, and we'll talk a little bit more about this, about their cognition and how that will impact what we can do with the patient's education and teaching. We're also macronutrient people, but we're also micronutrient people. So we're looking at vitamin, minerals, deficiencies that might be in play that we need to address and fix. We also look at the requirements of that patient, their fluid, energy, protein. So, and then making sure however they're consuming their diet and food is adequate, or if it's inadequate, let's fix it. So from all that information, we're going to prioritize a diagnosis or a nutrition diagnosis where we're really going to target where our intervention will be. And those interventions can be anything from manipulating the diet, providing supplementation, education. We might be also initiating, an enteral nutrition formula if the patient has a feeding tube need or a PEG access. And then we're going to monitor, evaluate the effectiveness of our interventions and This is what's really important because sometimes we lose track of our individuals that are discharged and then they're out in the environment and communities. And this is where the clinics that our patient that we're going to talk about today become so important because we really want to make sure that they're meeting their goals, but consistently even after discharge. So that's a quick snapshot, but I'm going to hand it over to Kelly, who's going to give you a little insight on the SLP.
Hi, everybody. Well, first of all, thank you for having us here today. I have a long history with BINJ, and thank you for still having me come, even though I've moved to Pennsylvania. It is much appreciated. Um, I am a speech and language pathologist by training. You might have heard SLP or speech therapist, and they all fall under the same umbrella, which, by our national organization standards, it's something along the lines of working to prevent, assess, diagnose, and treat speech, language, social communication, cognitive communication, and swallowing disorders in children and adults. Um, I tell people that we do everything above the neck is what I like to say. So similar to what Jen said, I work with NICU babies, right? I've worked with them on learning how to bottle feed. I've worked in geriatrics and older adults for end of life care and palliative care and everything in between. Um, Speech therapy, when I talk about it to people, they say, "Oh, I knew someone with a lisp who went to a speech therapist," or "I know an autistic kid who gets speech therapy and ABA." And, that is one small part of the scope of our field and all the things we do. So when I say I'm a brain injury specialist, people are very confused very quickly. Because then when they think of speech and language pathology, they don't necessarily connect it to brain injury. So some of the pieces that will kind of prevent, assess, and treat and work with people on are things like voice disorders. So, whether it is something like you are a teacher and you talk a lot and your voice keeps giving out, or you've been intubated and you have a voice concern after that, or head and neck cancer, we'll do that. Cognitive disorders is my bread and butter. It is the thing that I do the most of. And it's the idea that there are these invisible problem solving elements and thinking elements that sometimes aren't quite hit, but can prevent a lot of everyday functioning, especially after brain injury. Fluency, which y'all might know more as stuttering, is the idea of how smooth someone's speech is. We'll work on that. Social skills and pragmatics. Sometimes that's with autistic individuals. Sometimes that's with people after brain injury. There's a wide range there, but the idea is how do we connect with people? How do we actually communicate and build community and relationships and do it appropriately when settings change and circumstances change to fulfill some kind of psychological and emotional interpersonal needs that we have? Language disorders, and that is a whole class in itself. That could be reading, that could be speaking, that could be understanding, that could be listening and holding on to that information. The idea of language being something that we receive from other people, but it also is something that we produce ourselves. And the idea of language not always being spoken, right? Reading and writing is one section where that kind of happens in the head. Speaking, understanding, we understand from our actions. So we're really looking at all of those elements. Hearing impairments, um, especially after, we're specifically talking brain injury, but in general, we work for people who have cochlear implants, from people who have aided hearing, balance issues. Anytime hearing has decreased, that might impact the way someone understands, right? I think we've all been there, especially if you've lived through COVID and someone was wearing a mask and you're going, what? 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 There's that lack of understanding that comes from not being able to hear. So when I think about people with hearing difficulties and speech, I immediately think, how much of this are they actually getting of what I'm saying? Which can really impact, again, language and cognition and social skills. So you kind of see how they all are a domino effect, affect each other. AAC, which stands for Alternative and Augmentative Communication. And you can see the little iPad down there. Alternative meaning instead of, augmentative meaning in addition to. So this is for people who speaking verbally and communicating verbally might be difficult for one reason or another. And it doesn't have to be all the time. And it doesn't have to be in every situation. But we have people that use picture cards and boards, right? A lot of you might have seen picture boards that you point to um, a word or an object that you want communicated. We do iPads and iPad apps for full AAC access. And you've probably seen something like a Stephen Hawking eye gaze, right? It goes all the way up to there. So there really is a breadth that we do. Speech sound disorders, which is our back to our traditional articulation. But the one we're going to talk a lot about today is swallowing and dysphagia, and the idea of what happens once food is in your mouth and how do we get you back to eating what you want to eat. So, Jen, if you can go to the next slide, please. Yeah, so specifically for brain injury, I really focus a lot more on the communication, cognition, voice, and swallowing. And we work on the things that maybe you've heard these words before, like aphasia and apraxia and dysarthria, right? A loss of words, word finding issues. I want to move my mouth and it just won't do what I want it to do, the coordination, and dysarthria, which is motor weakness. We also focus on things like attention memory. So after a brain injury, if you're like, I just can't remember what I need to do today, I can't remember this person's name, that is something we work on as well. We work on dysphagia, which we're going to talk about a lot today, to support safe nutrition, functional communication, and a lot of education compensatory strategies. As you'll know, I always say that I am bad at remembering names in life, and expecting me to get better at that is not a realistic expectation. So sometimes I need to write things down. So it's not making the skill better, it's how do I support myself with the level of skill I have. And the long-term goal is always support to participation, whether that's home, work, school, social life. We're really focusing on those areas and collaborating interdisciplinary, like Jen had also mentioned. Next slide, Jen. So, what is dysphagia? When I describe dysphagia to people, I say there's two tubes in your throat, one that goes down to your lungs and one goes down to your stomach. And you can see them in this picture. The darker pink, there's two darker pink lines, and those are the two tubes, right? One goes down to your stomach, the other goes down to your lungs. Ideally, the food is going down to your stomach. And there's a little barrier called the epiglottis, and it stops food from going into the lungs because we don't want that, right? Food into the lungs generally equals aspiration, we call it, or penetration, which is the idea that food enters the lungs and potentially causes an infection. And over time, this could be something like aspiration pneumonia, um, which can be very dangerous for people. The other piece I want to talk about is the idea of what you are eating and how quickly it's going down. If you have difficulty chewing food, you might have an oral dysphagia, right? It might start in your mouth. And then when you swallow it, it gets stuck. You might have a pharyngeal dysphagia, which really is where those white arrows are in your pharynx, which means that swallow activation isn't as strong and it isn't pushing your food down the way it should. Um, when we're talking about this, we ideally want the food to go into the stomach. Now, if we think about a lot of us, and I say, have you ever drank something too fast or it's gone down the wrong pipe and you've coughed? I would say 99% of people would say yes. That is something going down the trachea, and your body saying, absolutely not, that's not where that goes. Let me get that out. You have a cough response, your sensory is working. With brain injury specifically, we have an element called silent aspiration, which means because of the injury, you might have reduced sensation, which means something might go down that way and you don't feel it. So you won't cough to protect your airway. So is aspiration something that happens to everybody in life? Yes. Are people with brain injury more likely to get things in their lung because of their neurological difficulties after the brain injury? Also, yes. And that's what we're talking about today. Next slide, Jen. Yeah, so these are predictors through dysphagia. I am not going to go through each and every one of these because we'll be here till May, but coughing and choking is a big one. Weight loss is another big one, right? If the food's not getting to where it needs to be for nutrition, we're going to see a potential weight loss, which is we always loop in our nutrition folks. Drooling, dehydration, regurgitation if food is coming up. Um, the idea of food sticking in the throat, gargly voice. All of these, if it's not sounding like you're able to swallow from the mouth and it go all the way down, if it gets stuck along the way, we're really looking at some of these pieces. On top of that, you could have one of these and potentially have a dysphagia. So we're like, obviously, this person isn't coughing and choking, but if they're having facial weakness, they probably still should be screened. If they're eating and fine, no problem, they swallow, but their voice sounds really gargly, like there's liquid stuck here, that's probably an assessment moment. So keeping these idea overall that they can be isolated and they also can be together. Um, so I'll talk a little bit about this. I mentioned aspiration pneumonia, which is on your top left. Um, the idea being if someone has a dysphagia, right? You have swallowing issues, difficulty swallowing, you have that decreased swallowing ability you can see at the bottom. That also decreased swallowing ability also may lead and frequently leads to malnutrition. And you can see how all of these things interconnect, right? If we have dysphagia and malnutrition, you're going to have difficulty healing wounds or healing your brain, right? Your healing processes are going to be significantly depleted. If you have dysphagia, you might get aspiration pneumonia, which will cause malnutrition. But also, if you're immunocompromised, you're at a higher risk for infection. This may also cause a muscle breakdown difficulties, which will decrease the swallowing ability, which then goes back to the dysphagia. And we're living on this merry-go-round of not being able to eat, potentially having an infection, not healing quickly enough, decreasing muscle mass, and we go around and around and around. So you can see how disease specifically can be heightened or worsened based on malnutrition and dysphagia. So it isn't just like, oh, there's some things in my lungs. Oh, I'm not eating the way I should. It really has a domino effect on the body. So I say this to everybody, and that's why we have cupcakes. In a situation like this, we might say, Kelly, you might change what someone's eating. And I say, great, amazing. I always want to make sure that the goal is safety and quality of life, not just getting rid of risk. If I told you you couldn't have steak anymore or you couldn't have burgers anymore, um, that might be a huge hit to your system, right? You couldn't have your coffee in the morning. Um, there might be a balance of risk versus reward, what you really enjoy. Are there ways to eat the food you want safely? So, as an education part, I want everyone to be thoughtful about maybe if I change the way I'm eating, my postural strategies, I tuck my chin, I head turn, I slow down the way I'm eating or the amount I'm eating at once. If I change environmental supports, a lot of clients I've had tend to be on their iPhones while they eat or watching TV. And sometimes just taking that stimulus away lets them attend more to what they're actually doing. As well as training caregivers and the idea of supervision. So if someone has coughs on water, I'm not immediately putting them on thickened liquids. I'm really working with the family. You're going to see that in our case today. The other thing is, I love this slide and I found this picture. We are not the food police. People are like, oh, their SLP is going to take food away from us. That's not my job. I am acutely aware that diet changes come with real costs, as is Jen. And the idea is if I tell you to do something and you don't do it, that increases the risk. My I told you so or I did the education does not prevent your infection. So it behooves not only you, but also me to work together to find a plan that you actually can stick to versus me telling you what I think, you going home and having that steak anyway, and potentially going back to our previous slides, having those kind of domino risk factors that occur. The phrase that I think about is least restrictive diet. What can I restrict that is absolutely necessary, but is still safe and functional? Um, if you are someone who is in speech therapy or has dysphagia or has a loved one with dysphagia, patient voice is something I advocate for very heavily. The idea of shared decision making, respect for preferences, identities, and lived experiences. Um, when we're in the hospital, you get your tray, right, of your chicken tenders and mashed potatoes and mac and cheese. Um, the number of families that I've had come in and be like, well, we have jollof at home, right? We have pernil. Like whatever the cultural food is that you're eating, I want to know what that is to make sure that I know it's safe versus trying my mac and cheese, which may not map to what you have at home. My goal is not to take food away. It's to help people eat safely, meaningfully, and with dignity. Um, you can go to the next slide, Jen. I'll also say that eating is a social experience, right? We have family dinners, we go out to the bar, we go out for dinner, brunch, drinks, breakfast. Taking that away is a huge impact. So, because of this, in 2000, the ITSE came out, and it sounds like a spider. It's not. It stands for the International Dysphagia Diet Standardization Initiative. Um, and what it does is it allows us to categorize food based on its texture and viscosity, so how it feels and how it's broken up, and how quickly it moves for liquids. And there's certain tests that we as SLPs do, and nutrition does, and nursing can do to be able to assess those to see what we can safely send people home on. So it goes from thin, which is like your water, um, for the liquids, slightly thick, mildly thick. I always think of it like a nectar, like a thin nectar. I always think of it like the juice that's in fruit cups. Moderately thick is more like molassesy, and technically, you can drink pureed, right? Puree is thicker. We then go to minced and moist, which we think of very small pieces that are very wet, soft and bite size, which you can eat with a fork, and then regular, easy to chew or multiple consistencies. So that's things like pizza, right? Pizza has bread and cheese and sauce and toppings if you have a soul, hamburgers, sandwiches, those normal everyday foods. Putting multiple textures together makes things automatically go to a seven. So you might hear they're a level three and a six. They're a level zero and a seven, right, in your hospital settings or with your SLP. Next slide, please. And this is the pretty chart that goes along with it. So you can see 0 to 4 is technically liquids, and then technically 3 to 7 is solids, depending on what you're eating. Um, and we look at these numbers separately. So someone might be a thin, but because they have something going on in their mouth that makes chewing really difficult, they may be on a 4 or 5 for their solids. Because it's not the actual swallowing that's difficult, it's the oral management. If you think about when you go and get a tooth pulled and you have to be on a soft diet, even though your swallowing is fine. So we're looking at this whole system and making recommendations based on that. So yeah, why change? This is an example of ITSE. My light up recommendation do not do is don't make this change without talking to an SLP. We should have done some kind of formal assessment where I get to see where the food is going. Because we talked about silent aspiration earlier, right? The idea being that you could be sending things to your lungs and you're not coughing. So I don't have x-ray vision. I can't see if it goes in your lungs. So a formal assessment is usually recommended to make sure that your diet is appropriate. Um, because if you have thick liquids and you don't like their texture, so you don't drink them, and then they're going into your lungs, and then you're dehydrated. Again, think about that merry-go-round of that cycle that we talked about. You can see in the picture something that's liquidized, and then these are carrots. So pureed, minced and moist, soft and bite-sized. And for the pureed, people say, well, why does it look like carrots? It's because puree foods look really sad on a plate. So sometimes they will put them in a mold. So they look like the food that they actually are from like a psychological perspective. Next slide. So quickly collaboration, you're going to see what it looks like. I, as an SLP, handle kind of the physiological side of dysphagia, um, getting what Jen in nutrition wants in their body to the right place, is the way I've always thought about it, Jen. Like, yes, I am the ramp that they put the ball down. Um, and we work together to see what barriers or gaps might be in the way to get that ball from the top to the bottom being the stomach. With the goal being patient safety. That is the number one thing that I'm concerned about. Um, Not that we're necessarily making the safest decision for the patient, but that the patient is safe, right? Within what they are deciding to do in their autonomy, like we talked about before. So we're going to talk about RH. He is a client that Jen and I both saw when I was assistant clinic director at Rutgers. He was a patient that came into our free speech therapy clinic in Newark. And we're going to talk a little bit today about him, his background, and kind of how we handled that into collaboration. So he is a 57-year-old male um, who literally called me last week. So he is very much a part of my life. He is a status post-pontine cerebellar infarct, um, which means he had essentially a stroke in his cerebellum. He's had two. This resulted in right ataxia. So if I have a glass or a bottle, I'm trying to reach for it, he would miss. That's what we call ataxia, right? You can't use coordination, you can't hit the target. Dysphagia with a PEG tube still in place, so a G tube. RH had a past medical history of diabetes, AFib, hypertension, hyperlipidemia, and he came to see us in Newark. He also was on Social Security. He also lived with his girlfriend who had cognitive deficits and was post a breast cancer diagnosis. They had limited resources and funding, no transportation. Um, from a psychosocial standpoint, this was someone who really needed coordination and support to be successful, which you'll see throughout the case. So I saw him on, wow, it's been a year. That's crazy. I've seen him a full year ago, and we talked about these strokes. And what came out of them was someone who was very difficult to understand because he had a significant dysarthria. Um, so his girlfriend would have to do a lot of talking for him. He couldn't do a lot of self-advocacy work. He did not want to use an AAC device. But because his girlfriend also had cognitive difficulties, it was a lot of education and constant questioning to get to the answer. Um, we talked about his dysarthria, he very reduced intelligibility, which means how much we were able to understand. Um, he also had a lot of voice difficulties. So it was very wet and gurgly. He also had a suction machine, still has a suction machine that he would take with him um, because he would constantly need, because he was drooling all day. So he would need to be suctioning all of that out. Um, his language was generally appropriate, but because people had difficulty understanding him, it was kind of a moot point at that point because if you're talking and no one understands you, your language is still compromised. Um, on the right side of the screen, you'll see like the real kind of things we honed in on with him. Um, Executive functioning, language, and visual-spatial skills. He had difficulty remembering appointments. He had difficulty navigating new environments. He couldn't read his own medical documentations, really struggled with planning, leaning on his partner, who also struggled with those things. But the biggest piece for him was his swallowing. So he had moderate to severe oropharyngeal dysphagia and was G-tube dependent. So he was recommended to only use the G-tube for nutrition, so nothing by mouth when I first met him. He was a significant aspiration risk with thin liquids. So anytime thin liquids, he would drink them, they would immediately go into his lungs. There was some improved safety, but he wasn't ready to be let go and freed at that point. So what all this is to say, reduced communication, high aspiration risk. On top of all of this, when I met him on Uvalde, he said to me, yeah, I really, really like, I use my YouTube all the time. And like this morning, like yesterday for lunch, I had a Whopper. And I said, what? And he's like, yeah, a Whopper, like a burger. And I said, pureed in the tube, cut into pieces. And this man was fully just eating an entire burger, which, as you can tell from earlier, was not part of his diet. So, this idea of diet non-adherence and safety, if you think about all the suctioning he had to do, and all of this really impacted his independence safety. So, his primary breakdown was motor execution, with the secondary impact of communication awareness and safety. We educated him on that not being the safest choice. As you can see, he continued to do that. Next slide. So we saw him once a week. He was eating all of his meals by mouth. And when I saw him, we saw him in April. So when we started seeing him in the summer again, he had had a 40-pound weight loss between the end of April and us starting the beginning of July. And if you think back to our original slides of when do you refer, this was the moment where I was like, Jen, nutrition, there's something going on here. We don't know if it's physiological, medical, psychosocial, but we need some support and resources. And I need my expert colleague to come in and help me to do a team with this case.
Yeah, so in our clinics at Rutgers, we try to we try to collaborate as much as we can. There are logistical challenges, I'm not going to lie. And so it took quite a few months for us to get there, to get us to see our patient and to have our students, my nutrition students, participate and be able to see the collaboration. The nice thing with this clinic is that it's not only speech, but PT and OT were there as well. So we had a really good experience with meeting our patient and also talking with other other professionals as well. So what we found, very similar to what Kelly outlined, is when we met our patient, we found that he was a poor historian as well as the caregiver. It was really difficult to find out from them how they understood how to provide nutrition through the peg. And that's what we were really focusing on, is how are you using the G tube? Because they say that they're using it, but he clearly had some remarkable weight loss, as well as we do nutrition focused physical exams. So we could recognize that there was muscle and fat loss, as well as functional status loss based on the physical therapist assessments, as well as that functionally he looked like he was declining, which lined up with the fact that he definitely had this significant weight loss, and including the majority of that being muscle. So we had to get creative to find out some of the history of what they were giving through the G tube. The only thing that the caregiver could remember was that the bottle had the number 1.4 on it. So we were basically able to, I was recognized I knew off the top of my head a couple of formulas that were 1.4, which means there's 1.4 calories per ml. So that was the caloric density. And I was able to kind of figure that out. We were able to determine what formula that they were giving. But what we found out was, based on their recall, they were supposed to give 5 bottles a day or at night and run it through using a pump, but they were fearful of running out. So they were only giving themselves 3. He was only giving themselves 3 bottles, which was pretty significant cut back on his caloric and protein delivery. And also, with whatever he was eating by mouth, it was very questionable what was actually being consumed in whole and also even digested and utilized as energy. So we found a very sort of scattered diet history, and also some pretty important discrepancies on what was ordered from the time that when he was discharged from the hospital that previous fall, and what he was supposed to be following at home with his peg tube, and what was actually being given. And that was, again, we sort of recognized that there was a fear there of running out of formula, and they were afraid that there was they weren't going to have coverage for it. So we also were able to observe Kelly and students to perform a swallow, just sort of like a swallowing exam at that moment. We sometimes call it a bedside, but he wasn't bedside. So he was just sitting with us. So we were able to observe their swallow assessment, and ultimately that recommendation of what we call NPO, which is nothing by mouth. However, in the same breath, the patient was still talking about the foods that he still wanted to consume and the food. So, we witnessed some classic symptoms of dysphagia at the clinic, as well as talking about if he was going to consume oral diet. We did talk about the types of foods that he was consuming, and that we fed that kind of fed into some of the education of, okay, if you're going to eat something, let's talk about things that would help you with your weight loss. So this is just a quick summary. It's a little detail and sort of a RD speak kind of stuff. But what we basically diagnosed, I wanted to show you that what we came up with is this patient has malnutrition. We diagnosed him with malnutrition, and the etiology of that malnutrition was what we call social environmental, which means that they, because of fear of healthcare coverage or whatever it might be that would withhold the formula, their own withholding was what caused that weight loss, was a contributor of the weight loss. And so decreased access to the formula, as well as their own withholding of the formula, led to that severe 13% weight loss and so significant fat muscle loss, as well as, low BMI, and just how we basically was reported from the patient. So this is just a reiteration of what we recommended. We reiterated with them. We wrote it down so that they could see it and they could follow the instructions. So knowing that we were going to educate them, it might be very difficult to recall those details. So we made it very, very simple in terms of how they should utilize the pump, how many bottles they should be filling the bag. They had the formula, they just were not utilizing all of it. So the other thing we picked up is that use of, the one thing we have to remember is hydration with our patients. They don't always drink water because of the dysphagia. So using that peg to give himself some water throughout the day was another part of our instruction too, because dehydration was also found. We weren't able to utilize, obviously, biochemistry at the time to evaluate in the clinic, but we could tell with some of that nutrition focused physical exam that his skin was dry. There were some dehydration that was definitely there too. And then, with Kelly and partnering with them, we talked about softer foods. Like if you're going to eat, let's talk about softer foods that you might like that could at least be the least risky food to consume, even though we knew he had some active aspiration. We also were encouraging a multivitamin. He had some medications that he was giving, so we were trying to pull in a multivitamin. So those were some of our summaries of what we did for our patient here. But in general, like what we found was together, we were able to inform each other. We talked amongst each other as well with the patients, but we talked about barriers that were impacting his adequacy of nutrition delivery, both enteral and oral. We talked about the impact of the inadequate intake on his weight loss and the presence of malnutrition. We also collaborated and discussed, that degree of dysphagia and where that food consistency level prescription would land, even though technically right now he should be without any diet consistency change. But at the time, Kelly was setting up another modified barium swallow for him to reevaluate if there was any improvement in that aspiration. We also just talked how to navigate this limited access to care, these limitations of how to get the information and get the formula, things like along those lines, and making sure that those needs are met, as well as thinking through other colleagues that could help us, social work or anyone else that could help us with that gap of need. And then also we talked together about the impact of his nutritional health decline on functional status. So talking with our colleagues with PT, they were able to give him some exercise and instructions on, and just how to utilize things like his walker a little bit more easily so that the functional status was more intact. We referred to a little bit already just the barriers that were existing, and what we see with brain injury is that we just to reiterate a few things is you do have to be mindful in how we ask questions. We can't just unload the questions and just like fire them away. We had to keep them very simple, easy, direct, easy to navigate. I used images, writing things down, things that could help with them to say yes to that, no to that, rather than just asking them to freely open up and tell us a history of their diet. We had to find those right prompts to give them a cue to knowing what to say and how to get that information from them. We expect limited history. It's going to be challenging to get that history, but we do need you need to get creative or having that finding the caregivers support and what they're able to do is always a huge one. And also just how we educate. So what we're going to give them, what they're going to go what they went home with was a very clear instruction that we wrote out in simple terms that they could put on the refrigerator or they could put, next to the formula. So where they could, and that would be just for the enteral nutrition of what they're going to give to themselves in the G tube, but doing the same thing for, how you educate, and you might have to re-educate on things like consistency of the diet and the food and just areas of food modification in general. So those are just a few of the things that you want to approach and be very mindful of. These next two slides, I'm just going to sort of skim through it. These are just because we're getting towards the end, but these are just some general things that we would monitor, both of us as the RD and the SLP. We certainly are going to monitor things like weight gain, how he transitions from the enteral to oral diet, hydration, and just those symptoms that would lead to poor intake or there more dependency on the enteral nutrition. We're always with our patients that are on enteral and oral diet. We're finding that balance of let's not stop that enteral nutrition too quickly because then they can really flip into that malnutrition space pretty quickly. And then as for SLP, I'll speak for Kelly, she certainly can chime in, but when they're looking to transition someone from off of enteral nutrition and eating 100%, this may not necessarily be our patient, but we're looking for that resume of feelings of hunger. You're wanting to make sure that patient can navigate when they're full and when they're hungry. That's a really important sensation for them to recognize. That helps with transitioning them to eating adequately. Oral cavity is a really big part of care for patients, especially those who are on long-term enteral nutrition. We can't ignore the fact that oral health is a really big part of their care. Caregiver support, of course, knowing that there might be caregiver fatigue as well is going to be a big part. And Kelly mentioned cultural preferences. That all factors into quality of life. That all factors into nutrition as well. And then we look at things like medications, especially those that might be impacting their ability to swallow, that could change sensation or motility, because those things, we don't want anything else making it harder for them to swallow, to make a swallow safer. And then again, the same with us, we're looking for their ability to tolerate their diet in their gut. If there's any gut response, we're watching that. And then utilizing radiology and mattifying barium swallows, things along those lines to help us with more further assessment. So just overall, our patient has, he's still, because Kelly mentioned, he is still attending the clinic and touching base with his favorite SLP. We do know that he still is, navigating those socioeconomic and social challenges, but, he is plugged in, which we're very grateful for, and he's utilizing these free clinic spaces. He is continuing the G-tube use, and at night, we don't have an updated weight on him, but based on some of that reports, they are consistently showing or telling that they are utilizing it more along the lines of what our expectations will be. But we do see that the weight is at least stable, no further weight loss, which is a win in our minds. So, and just, including more professions in his collaboration, OT, PT is also something that is continuing as well. So we really feel that brain injury is interprofessional collaboration. Not one person can really help with total care of a patient. We feel nutrition and speech language pathology, we are specifically a great team for individuals that have difficulty meeting their nutrition needs with an oral diet. And it's not just dysphagia. It can also, as Kelly said, there's a lot of things that can change or impact the ability to chew, swallow food, not just a physiological diagnosis of dysphagia. And then we know that these individuals can be prone to developing malnutrition very quickly. And like we mentioned before, that can be this vicious cycle. Malnutrition just leads to worsening of other symptoms that can prolong, poor health outcomes. And quality of life is always a priority. But we're grateful to know that BINJ can help. There's support groups and care lines. So you guys know that you're in a good spot to get some support there for those that need it. And these are just some additional resources for you. So I'll stop sharing. And if we have any questions, we're happy to take them.
Thank you so much, Jennifer and Kelly, for that most informative presentation. We can take a few questions now. We do have a few minutes. I don't see any in the Q&A right now. If you do have questions, please type them in the Q&A or the chat, whichever is easiest for you. I will say that I love the link between the quality of life and safety. I think that's often in rehabilitation a balance. And still wanting to preserve those favorite foods versus the safety risk. So, again, just that it's at the forefront of the conversation, I think is amazing. And using the food police, because we hear that all the time,
Oh, yeah.
and the least restrictive diet, as well as the patient's voice matters. So I felt like it was very person-centered.
Yes.
Not that I would expect anything less from you both, but just highlighting that.
Yeah. Yeah. No, we try. I mean, even with us, oh my gosh, if speech therapists are called food police, then we're called the food like FBI or something. I don't know. Like we're usually more under the bus when it comes to like you can't eat this, can't not eat, and we're really trying to. I mean, I'll probably speak to this in the next lecture, but just really trying to respect individuals' food choices. Culture is such a big thing, and there is no one pattern of eating that will fix everybody's problems. It's just really finding what works for you individually, but also being aware of food safety or patient safety, which is what we deal with a lot with dysphagia.
Absolutely. So again, thank you for sharing your expertise with us today. If you do have a question, please email me at klaw@bianj.org, and I will try our best to have our presenters answer it. Final reminder that the post-webinar survey is in the chat. The link can be found, and you can automatically receive your certificate of attendance. Thank you again for attending and for your thoughtful questions or your time and attention. We hope that we will see you next week or 2 weeks from now on April 28th, where Jennifer will be back with us to discuss how medical nutrition therapy supports brain injury care.
That
This
was good.
concludes today's webinar. Thank you so much.
Thank you all. Have a great day.